Hello. Doctors Coleman, Ms. Biskey, thank you for the invitation to speak today. It's a great pleasure to be here. So you've just heard from the previous talk how to treat the fit patient with 3 or 4 drugs in induction, and I'd like to discuss how we may treat the remainder of newly diagnosed myeloma patients who are not fit for these types of treatment. The title of my talk today is Management of the Unfit and Frail Multiple Myeloma Patient. As you may notice, the title is not Management of the Elderly Multiple Myeloma Patient or Transplant Ineligible Patient, as the standard practice of evaluating and selecting treatment based on chronological age and transplant eligibility is being re-examined. These are my disclosures. So I'll divide my talk into 3 parts. The first part will review evidence-based treatments in the elderly and historically transplant ineligible population. Next, we'll define fit, unfit, and frail patients using one of the more recently published frailty index scores. And then the last part of the talk, the bulk of the talk, will discuss evidence-based treatments in the unfit and frail population, and hopefully provide a treatment landscape for the present and future for these patients. So nearly 2/3 of multiple myeloma patients are over age 65 at diagnosis, the bulk of our patients we see in the clinic. The median age at diagnosis is 69, and on the right-hand side of the slide, you'll see that the median age of death is 75, and that almost 80% of patients, mortality we see in patients over 65 with myeloma. And just as another note, that we know that our population in the world is aging in general, so that this will continue to be a larger portion of patients that we treat. We have seen continual improvement in survival across all age groups, in age groups over 65 as well. This was one of the more recent data sets I've seen looking at analyzing the SEER data set. And if I draw your attention to the age 65 to 74 group, we've definitely seen improvements in survival with novel therapies, both 5-year relative survival rates to the general population and 10-year. However, in over 75 age group, we really have made much less progress, no progress in 10-year relative survival rates, being less than 10%, and some progress in the much more recent years, but definitely a more at-risk group. And just again, as a background, what has led to these improvements in survival, particularly in the 65 to 74 age group? And I've kind of mapped out a timeline here of the trials that really have, in specifically transplant ineligible population historically, that have led to these improvements in survival. So here we see over 6 trials in improvement with melphalan, prednisone, thalidomide, then a subsequent improvement adding bortezomib to melphalan and prednisone. Then in 2010 reported another paradigm-changing regimen, lenalidomide with low-dose dexamethasone. And just an important caveat here, and there are about half the patients in this trial were over 65 years of age. And one caveat I wanted to mention is that the fewer deaths that were seen in the low-dose dex arm were primarily due to fewer deaths due to toxicity in the first 4 months of treatment and in the elderly patients. So that was a learning point from this study. VMP compared to VTP showed similar overall survival that we saw with in the prior trial, roughly about 5 years. And then I list these trials here. We're not going to go too much more into them, but just to show that there were older patients in these studies as well, and I'll show you on the next slide. However, definitely data that benefits and will likely benefit this population in the future. The first trial really also being paradigm changing with continuous lenalidomide shown as showing a survival benefit to MPT, and then much more recently, the first 4-drug regimen with monoclonal antibody 4-drug regimen that was reported earlier this year, also showing a very strong PFS benefit versus VMP. So I just want to show these triplets here, so novel triplet combinations that were not looked at. These phase 1, phase 2 studies were not looked at in a transplant ineligible population, obviously, but there were small numbers of patients in these trials that this data, in the IRD data updated more recently, highlights the response in the older patients over 65 years and over 75 years, and we see very strong survival and responses in these older patients as well. And we'll certainly have more data to come from endurance and tourmaline trials with older patients that we will be able to look at in more depth. And then, as just I mentioned, the 4-drug combination in transplant ineligible newly diagnosed patient adding daratumumab to VMP backbone, and that's with continued daratumumab maintenance in the DVMP arm. And this was in a purely transplant ineligible population, or over 65, over 700 patients, 30% over 75 in each arm, with primary endpoint being PFS, and a very strong hazard ratio, decreased progression or deaths in the DVMP arm, hazard ratio of 0.5. And one I want to point out here, in the subgroup analyses, the most recent from the recent publication in New England Journal, showing that despite over 75 or under 75 age group, we see very strong hazard ratio, similar 0.53 in the over 75 age group, so that these older patients are appearing to benefit from the addition for the 4-drug regimen. So now, how, highlighting some of these improvements and progress we've made in the last 12 years, I'd say 12, 15 years, in a transplant ineligible population, we know, and we all know, that most of these patients we would be considering fit in these trials. So how is this data and these studies going to help us in the real world, real clinic, in treating our frail patients, or possibly an intermediate category, our unfit patients? So that's what I really want to dive into deeper next. So, first, a definition. Dr. Palumbo and his group in the IMWG published this analysis in 2015 in Blood, looking at 869 patients from 3 pooled studies where a geriatric assessment was performed at baseline, so that different risk factors could be analyzed to look at. And their question was, are there risk factors in older newly diagnosed myeloma patients that predict mortality and increase risk of toxicity? So here, just to kind of quickly show you, and the point of this is that it's a simplified geriatric analysis that can be done, at the bedside in the clinic exam room quickly, so that we can really make this accessible to our clinics. These 4 risk factors were found to be the highest correlation with mortality in this data set of 869 patients. So between age, the Charlson Comorbidity Index, activities of daily living score, and the IADL score, these 4 risk factors, when added and in getting a score that would delineate 3 different risk groups related to survival. And so a frail score of greater or equal to 2 being associated with the frail category, and each of these categories were about 1/3 of the patients in this group. And it actually, looking at it in this way, in relation to other risk factors that we're seeing in this data set, you can really see how strong this frailty score was compared to age alone, even cytogenetics. You can see the hazard ratio here of 1.72 between under 75, over 75, 1.86 between standard risk and high risk, FISH, and then when we look at just the frail versus the fit, a 1-year overall survival of 96% in the fit patients versus 78% in the frail, with a hazard ratio of 3.53. So very strong correlation with survival. And additionally, the goal for this study was to not just look at morbidity and survival and progression-free survival, but also toxicity and risk factors for early drug discontinuation as a reason for decreased overall survival. And you can also see in these two lower graphs that the cumulative incidence of non-hematologic AEs did also correlate nicely with the 3 risk groups, with higher AEs in the frail group and lower in the fit, and then drug discontinuation, really we see the 3 groups separate nicely. So, as a conclusion to this data set, one proposed, management strategy of, okay, we divide our patients into fit, unfit, and frail with this score. What next? How do we treat these patients? So, one proposing of either lowering doses, lenalidomide, but lengthening treatments, so every other week versus weekly. Bortezomib was proposed as one strategy for these patients. But we really have, just in the last few years, since this has been published, have a little bit of data that's now coming out focusing specifically on the unfit and frail patients. And that's really what I want to review today. So yes, we can decrease dose levels of standard induction agents, which we kind of do that as a gestalt, and we do that on our own. But is there evidence for regimens or any evidence in the literature for other strategies or treatments that we should be doing specifically in these patients? So one option would be, the question, should we give these patients doublet or triplet induction regimens? And there's 3 main large trials that I'd like to review with you that really looked at this question in the unfit and the frail population. Two were from Europe, from Italy, and one was led by Dr. Niedzwiecki, the upfront study. So the first was looking at lenalidomide-based doublets versus triplets for 662 patients in a large phase 3 study, all over 65 or transplant ineligible, and comparing RD versus an alkylator triplet, melphalan prednisone Revlimid or Cytoxan prednisone Revlimid. And here I highlighted not just the overall study population. There was found to be no difference in survival between the 2 alkylator regimens and the doublet, but even looking at the response, the PFS and the OS broken down by unfit or frail in each of the doublets or triplets, we really see no difference in responses here. The same, almost identical concept study was done, a smaller phase 2, looking at this question, but with bortezomib-based doublets or triplets. So 152 patients, again, Italian study were randomized to bortezomib prednisone VMP or bortezomib Cytoxan prednisone, and all arms had a bortezomib maintenance. And these, and I didn't point out in the last slide, but this data set was from the same group and who published the frailty score, and they categorized in their patients as unfit, frail, or fit coming into the study, and so 54% of these patients did meet the frail category. So in 76% over age 75, and so forth. And the same conclusion, PFS, OS, no difference between the doublet and the triplet regimens. And then the upfront study over in the US was done, and what was unique about this study, looking at doublet versus triplet bortezomib-based regimens led by Dr. Niedzwiecki, so VD versus VTD versus VMP, so looking at a triplet IMiD and PI combination therapy. Over 500 patients were enrolled, primarily at community-based practices, and these patients did have a high number of comorbidities. A portion were over 80 years old, very elderly, and we see the same conclusion that there was no difference in survival, PFS or OS, between the doublets or the triplets. In the VTD arm, there was a much higher rate of toxicity and decreased quality of life reported in that the arm specifically. So other evidence, and some of the strongest evidence we have for how we now are managing our unfit, our frail patients, if we can't combine to triplets and 4-drug regimens in these patients, at least at the present time, can we lengthen their treatment and lengthen PFS by continuous therapy, either with a doublet or a triplet as an induction. So everyone knows the first study, and this was in a purely transplant-ineligible population, over 1,600 patients randomized to that question, continuing Rev maintenance or stopping Revlimid Dex at 18 cycles versus continuing Rev and Dex versus 18 months of MPT, 12 cycles of MPT. And these patients were also, there was a portion that were over 75 and higher risk. And, just as a summary, the trial met its primary endpoint for PFS with both overall survival and a progression-free survival versus MPT. For the fixed versus a continuous Revlimid arm, there was a progression-free survival and a trend to overall survival, but was not significant for overall survival. Both arms were approximately about 5 years. And in the most recent, there was a recent update to the first trial published earlier this year, and in this update, there was subgroup analyses focusing on age and other risk factors. And just the main point I want to make here is that for the younger and the older patients, younger or older than 75 years, that we see the same benefit for prolonged PFS regardless of age. And so this regimen does appear to benefit our older patients as well. Now, stemming from that, I have a few slides on the Swagg study. So the phase 3 study of RVD versus RD, and this was not in a purely transplant-ineligible population. Only 43% of patients were over 65, and only 1/3 were transplant-ineligible. However, the question, we know that this study was basically RVD versus RD, both arms with RD maintenance, similar to the first study, and we know that it was strongly positive for RVD. So the question here is, will this regimen benefit our frail patients? In the subgroup analyses of this study, breaking down the 65 to 75-year-old patients, there was a trend to improved PFS and OS with RVD that did not reach statistical significance. In the over 75 age group, there was both a doubling in PFS and OS in 30 to 60 months overall survival. So a strong benefit that was statistically significant. So it was a large study, and I think this data is very provocative for these patients, again, with the caveat that these are likely all fit patients. So going back to how do we treat our unfit and frail patients using this information, the last study I want to review is a very reasonable question. We know that there was a benefit to RVD, so in all comers. So can we modify this regimen, attenuate the doses for transplant-ineligible patients? So this was a phase 2 study. Median age was 53 patients, and basically modified every component of this lower dose of Revlimid, 25 to 15, weekly bortezomib, and with the cycle being 35 days versus 21, Dex capped at 40 a week, 20 in older patients as opposed to 80. And there was a consolidation phase of 6 cycles after the first 9 cycles, and 2/3 of the patients, even though it wasn't written into the protocol, did go on to maintenance therapy. So similar to the Swagg study in that regard. And there was, again, being a phase 2, we'll there's, take that as to note, but despite that, a very prolonged median PFS of 31 months, and just to put that in comparison with the first study, median PFS being 26 months in the population, and with the RVD study with not just transplant ineligible patients being 43 months. So was good. The primary endpoint was overall response, and we can see that the very low rates of peripheral neuropathy, only 1 grade 3, very low rates of high-grade hematologic toxicities. So overall, this was very promising. Now, don't want anyone to get a headache, but I really just wanted to kind of give a roadmap for where we're at right now in terms of thinking of FIT, with all of the new 3 and 4 drug regimens that you've just heard about, and how we can put our unfit and frail patients into this time period. So, I've listed the phase 2 and phase 3 studies for triplets and 4 drug therapies, and, by and large, these are going to be all for fit patients. I outlined these 2 studies, KTD versus KRD, and a new study, it was a 4-arm now, it's a 3-arm Ixodex, Ixodexthal, and Ixodexi with Ixa maintenance, and these are in a transplant ineligible population. However, most of the studies now, and if you look through the clinicaltrials.gov and look through all the study details, you'll see that many are excluding now based on the frailty index. So even this trial, the frail patients are excluded. So are there trials for our unfit and frail patients? There's a few that I just want to highlight before we end. The concept of a monoclonal antibody-based triplet. There's, we all know the Eloquent study, but DARA Revdex versus Revdex, or a smaller DARA Velcadex. These are trials that possibly are unfit patients, if they're not explicitly excluded, could qualify for, and may be able, have low toxicity. And then lastly, for our frail patients, there's not, the main point really that I'm showing you this is we need research, we need to study these patients. I mean, we have, a few trials, and they're basically modulating steroid doses, and this large phase 3 trial is asking, do we continue, 25 of Rev or drop it down to 10 for maintenance? So I would, say this is not going to include our frail patients anyway, but possibly our unfit patients. So conclusions are that the IMWG frailty assessment is a very accessible one that may be used in all newly diagnosed patients who we deem at risk. The definition of frailty will continue to evolve with introduction of novel and more tolerable therapies, such as monoclonal antibodies. And just as a small roadmap, the current treatments and current trials that we may consider for these patients, either doublets, low-dose doublets, followed by continuous therapy, attenuated triplet combinations such as RVD light, possibly monoclonal antibody-based triplets. And I'll leave here, it's just kind of more of a summary, and the top half is how we are treating these patients now, focusing on the unfit and frail categories, and the bottom half are, in the very near future, hopefully from current studies, what we may have to offer these patients. Thank you.